To Reservationless Plus Conferencing, enter your conference code, followed by the pound. Thank you. After the tone, state your name, followed by the pound or hash sign. Thank you. You will now be placed into conference. To mute your line, press *6. To unmute, press #6. Your conference is being recorded.
A copy along with a recording from the webinar. Also, these resources and recordings, along with other resources from the past, are also available on group sites where you can find previous resources, engage in conversations with your colleagues regarding best practices and so forth. And if you haven't done so already, I urge you to please log on and test out the website. Also, if you haven't received a group site invite from us, please let me know via email or please reach out to me over the phone. So even though we have gone through a webinar around ACA, there still remains lots of questions and concerns. So today we have among us Shawn He is the Associate Vice President of PCA and Network Relations from NACHC, who will be giving us an overview of the national perspective of the ACA. This webinar will give you more clarity on what you can anticipate relative to funding and ACA implementation. So without further ado, I'd like to have Shawn take over from here. Take it away, Shawn.
Thanks, Anika, and good morning, everyone. This is very much a unique webinar that we're doing today in the sense that the audience, Maryland and Delaware, are in very, very different positions versus compared to the rest of the country. Quite frankly, the rest of the country is very, very much in play still in terms of what the Affordable Care Act is going to look like at the state level. But in much of these cases, at least for Maryland for sure, you're so much further ahead of than the remainder of the states in terms of implementation and what it's actually going to look like, and you should certainly be commended for that. So for some of the things I'm going to be talking about, clearly a lot of these issues that I'll be bringing up are going to be not necessarily relevant to Maryland, but will certainly give you an idea of the other issues that are taking place out there and that might actually materialize maybe in Maryland or Delaware down the road. So if you want to, Anika, if you want to go ahead and go to the next slide. And actually go ahead and go to the next one, please. And, someone asked me, my title is actually Vice President of PCA Network Relations. I actually have a third responsibility, and that is basically the strategic implementation of the Affordable Care Act. And someone asked me how I got so lucky to have that, and it's because I've implemented Medicaid managed care in 2 states across the country, once in Illinois. Actually, we tried to implement, we actually stopped Medicaid implementation of managed care implementation for the Medicaid population in Illinois. And then actually had a Medicaid managed care implementation in the state of Ohio. So I've seen how basically this looks at the local level. And when you look at the Affordable Care Act, what it really comes down to, it's managed care. That's all it really is. You can easily get caught up in a lot of different issues, but when it comes right down to it, it's the implementation of a managed care product onto a new population. And so obviously there are very, very there are very critical issues that must be addressed and always must be understood when you go in that direction. So the initial slide just sort of lays out kind of what we're dealing with in Washington and with the proximity of Maryland and Delaware. You guys see this all the time. Everybody talks about the train wreck, and this is actually the quote that was said by Senator Max Baucus, who's the chair of the Senate Finance Committee, regarding a train wreck coming down. And quite frankly, while it was certainly a dangerous comment to be made, it was probably the comment that spurred the administration to recognize that they were really, really not moving forward and quickly enough to make the implementation dates coming up of October 1st and obviously January 1. And then just a couple of days later, this was the quote from the Washington Times, in terms of House GOP rejoices in vote to repeal Obamacare. And actually that's dated, obviously, at this point. The House Republicans, in some fashion or another, have now tried to repeal all or parts of Obamacare, of the Affordable Care Act, 40 times at this point. So it is true insanity here in Washington, D.C., and unfortunately, it has not gotten any better as we've moved towards implementation, and we'll get into that in just a couple of minutes. If you can move to the next slide, Anika. So this is kind of where we're at. I wanted to kind of give everybody, when we always do these presentations, always kind of like to give a lay of the land on what we see in terms of the appropriations, because obviously all the health centers are so focused on increasing access to care. And so, as everybody's aware, we were not, we did have to take a cut due to sequestration. However, we were obviously lucky enough to be able to backfill that due to the Community Health Center Trust Fund from the original passage of the Affordable Care Act. So we had for fiscal year 13, which is what we're in right now, we had a $300 million increase as a result of the trust fund, 112 of which 112 of our total appropriation had to be reduced due to the sequestration. I think probably most of you are aware of these two next numbers. The $48 million, which was set aside for new access points, the $48 million, which was set aside for base grant adjustments, we expect to have those announcements probably sometime in September. And the $19 million for new access points, we were kind of hoping they were going to be introduced at the CHI a couple of weeks ago, but they've chosen to wait until September on that as well. We expect somewhere between 6 and 10 new start community health centers. There'll be about 25 total awards made. Between 6 and 10 of those will be completely new starts. The rest of those will be expansions of existing sites. And then, obviously, everybody knows about the outreach and enrollment money that was sent out about a month ago now to each health center. Anika, real quickly, how do you want to handle questions? Should we wait till the end? Is that the game plan?
I think that's the best way to do it, unless, Shawn, you prefer getting them as you go along.
I'll tell you what, I have no problem being interrupted with a question, and I will stop a couple of times just to make sure that I'm clear on a couple of points. So if that works for everybody, we'll just do that way.
Yes.
So that's where we're at, obviously. One of the main problems with the climate we have here in Washington, D.C. is the simple fact that we can't, the Democrats and the Republicans aren't really agreeing on anything. Most in particular is the budget process. We are actually in the last month of the fiscal year 13 budget appropriation process. We should be well on our way into 14, but that's simply not going to happen. So I can give you an idea of what's working or what we've done so far in terms of fiscal year 14. Once again, back to the Community Health Center Trust Fund, there's an additional $700 million this year. We have every intention of taking that $150 million for outreach and enrollment, and the actual number is about $142 million is what was actually used for outreach and enrollment, and actually trying to roll those into a base grant adjustment for the health centers that received them. Obviously, that's completely contingent upon that $700 million becoming available to us. As everybody knows, we took a $600 million hit on the trust fund about 3 years ago, and so there's, we always need to protect both the regular appropriations as well as the trust fund money to assure that we come out ahead in this conversation. So, also trying to push for the expenditure of that $700 million just as soon as possible in terms of new access points, expanded medical capacity, service expansion, etc. I will tell you that the health centers, or the NAC in particular, I apologize, I need to reset my computer here. The NAC in particular is pushing hard that there be less money set aside for new access points in terms of new starts, and focus the amount of money that we have available toward existing health centers in terms of increasing service expansion, the expanded medical capacity, that type of thing. So that is really what our goal is. As everybody knows, starting a health center is difficult, and especially in this time, it is incredibly difficult. So much more to come on that, though. We really only expect to see a continuing resolution similar to what happened this year, and probably not get a final budget until probably well into a calendar year 2014. Next slide, Anika. So in terms of the Affordable Care Act, unfortunately, this is a slide that seemed to work well for several months, and unfortunately things have changed dramatically. Now I'm going out to the nation as a whole. While this looks perfectly normal to the people in Maryland and in Delaware, this is not going to be an appropriate slide moving forward, because we probably need to put something right in between the middle there where it says state exchanges and Medicaid expansion. As a result of some of the things that are happening across the country, particularly in Arkansas. And I'll get into the Arkansas waiver in a little bit, but basically a lot of the state governments, the Republican administrations in particular, are trying to create a hybrid of programs here where they take they want to expand Medicaid, but they want to use it using what they're calling a private option. So, and it's a very unique thing that we're still learning about. Arkansas is definitely moving in that manner, in that direction, as well as Iowa has done something similar. And if anybody read the paper just earlier this week, Indiana has basically said they are going to go in that direction as well. What it comes down to, though, is that these are all, once again, with the exception of the regular Medicaid program, a lot of these programs are moving toward what would be called an exchange type of a product, where you actually, once again, it is a managed care product. So again, we're going back to that issue of this is all going to come back to managed care contracting and our ability to make sure that we are getting paid appropriately, and that we're looking at our contracts from a very holistic perspective in terms of the financial side, the quality side, and the administrative side to make sure that we can meet the demands. Next slide. There you go. Okay, so this is kind of where we're at, and once again, there's new information as of yesterday. Across the country, approximately 120 insurers applied to be qualified health plans through CMS. I actually had a meeting with HRSA yesterday. Yesterday was actually supposed to be the day that was originally slated that CMS was going to release the names of the plans that were approved. And once again, I should say this is all for the federally facilitated exchanges. States like Maryland, who have been far, far more aggressive in terms of getting a state-based plan up and moving, this is not something that those states need to worry about. The state-based exchanges are running far, far more smoothly than the rest of the federally facilitated exchanges. As a result, as I said, 9/4 was supposed to be the day we were supposed to hear. We were told yesterday, frankly, we're probably not going to find out who the qualified health plans are for the federally facilitated exchanges until 10/1. Now, obviously, that next line is critically important, because 10/1 is October 1st is the day that open enrollment begins. How in the world we're going to have any kind of the health centers or any of the other groups that are doing outreach and enrollment are going to have any collateral to be able to talk to patients is beyond me. If they're not going to give us a name of a QHP in those states that are federally facilitated until October 1st, I would anticipate you're not going to have collateral ready to go in terms of the options you have in terms of the silver, gold, bronze plans. So probably, I'd say at least the second or third week in October at the very earliest, and then obviously that just shrinks the time we have to get people enrolled even further. We had just a matter of 3 months, and it's probably going to be down to about 2 months once everybody gets their information out. I think everybody knows on this phone call, one of the huge issues we are facing, probably the primary or the number one issue that we're facing across the country, is Medicaid, is states choosing not to expand Medicaid. As a result of the Supreme Court ruling, exchanges absolutely are moving forward in all 50 states. Most states chose to go with the federally facilitated exchange, but the thing that we thought for sure was going to be rolled appropriate was Medicaid expansion, and it simply was not. Did I have a question? Did I hear a question on there? Okay. And as we can talk a little bit about this, I personally believe that there's a whole lot of politics going on right now in terms of states holding back on Medicaid expansion for political reasons. However, I do think over the next probably 3 to 5 years, you're probably going to see almost every single state expand Medicaid. Very similar to what the take-up was when Medicaid was funded in the 60s. You know, the last state to actually take it up was Arizona in 1982, and then same thing with CHIP. CHIP took a couple of years, took a lot less time to get fully implemented across the country, but Texas was actually the last state. I believe CHIP was originally passed in 96, if I recall. On the bottom of that slide, there's actually a link to a document that we created a couple of months ago kind of explaining this issue. Next slide, Anika. So this is sort of this is literally as of earlier this week, I believe, actually June 14th, 2013. And it's very interesting. This is a map of the United States. And there's various ways to show this thing. We're calling it state decisions on Medicaid expansion. And if you look at, it's where the states stand as of June 14th, but then it's where the governors are at, actually, is how this one is done. You can do this in various ways in terms of where the General Assemblies have actually taken action in individual states and use it that way. The numbers look a little bit differently that way, so it all really depends. But really what I would point out to you are those states in blue. Tennessee, Arkansas, Iowa, Indiana. Those are the states that are really going to dictate what happens moving forward. For the rest of those, I guess I'll call them teal colored states. I hope they look that way on your screens as well. Obviously, the red states have a long, long way to go. Or I'm sorry, I'm not saying that correctly. In terms of those regular blue colored states, that's going to impact the rest of the red states and how they are going to move forward, because as everybody knows, Arkansas has put in a waiver request for what they're calling a private option, and the private option basically is turning Medicaid patients into an exchange type of a program. And depending on how CMS allows the states to move forward, you'll see a lot of those states. I'm using the word claim victory by saying they're able to reform Medicaid and then move forward. All states recognize that there's too much money on the table from a hospital perspective, from the entire medical provider community perspective, not to move forward with Medicaid expansion, but they do need to find some political common ground where they can move forward without having to I guess I would say embrace Obamacare or embrace the Affordable Care Act. So pay attention to pay attention to Indiana and Arkansas in particular, and I think that when you see what CMS approves for them, you'll see a lot of those states move in that direction, effectively getting Medicaid expansion but calling it something different. Any questions about that I can answer? Okay, Anika, next slide. I know this is very, very different in Maryland in terms of, because the state has been so deeply involved, and obviously the community health centers have been deeply involved with creating the process. But across the country, what was passed in the Affordable Care Act was not what we are implementing at this point. CMS, a lot of the things that were guaranteed to community health centers through the law, when it went through the CMS rulemaking process, was changed quite dramatically. The law simply states that all 340B entities should get a contract with a qualified health plan. Instead of moving forward with that, CMS chose to err on the side of caution, I guess is the way to say it, to assure that there were going to be qualified health plans or health plans generally interested in becoming a qualified health plan. And so what they did, in terms of the essential community providers, they chose to go with a very minimum threshold of 20%. So those providers, or 340B providers, were lumped into 5 different categories, and basically CMS said so long as you have 20% of those essential community providers in your networks, you are going to be eligible for a qualified health plan. Now, obviously, we have fought strenuously with CMS on this rule, because it does create some terrible situations for health centers, especially in urban areas. If you have multiple health centers in a large city serving 10, 20,000 patients, there's going to be a significant could be potential for significant problems between the health centers in terms of health centers that agree to sign a contract with a qualified health plan and potentially other health centers that are going to lose patients as a result of that. So it's a very tricky situation that a lot of health centers are running into, right? Well, I shouldn't say running into, but going to run into when the qualified health plans actually release their networks. As I said again, CMS definitely is trying to work. CMS's goal on this is to stand up the Affordable Care Act, and so that is why you see this language. It's definitely watered down in terms of what CMS has chosen to do on this, and that also goes on the side of what's going on with those states that I just mentioned earlier, Indiana, Arkansas. They're definitely trying to do everything they can to get states to expand Medicaid. Whatever the state is calling it, a private option or whatever, it's still a Medicaid expansion, and so CMS is definitely bending over backwards to get as many of those done as possible. Another issue in that, in the essential community provider language simply says that you are not, qualified health plans are not required to contract with every community health center in the state, so therefore PPS is really a problem at this point. The community, if you are not required to have a contract with every qualified health plan, the requirement is you get PPS unless you negotiate a different rate. Well, if there's no requirement that I have to contract with you, it's very, very much in the control of this conversation is definitely in the qualified health plan perspective, because they can offer basically any contract they want, and you know, obviously the health center can negotiate for whatever it can, but there's no requirement that the QHP actually has to have all of the health centers in the plan. So that's a very, very big issue for us. We have been consistently working with Congress on this. Obviously, there's no chance that the Congress is going to open up the Affordable Care Act for amendments. We simply want Congress to push CMS to follow the wording of the original Affordable Care Act language. Any question on that issue? Okay, Anika, next slide, please. Now, so this is where it gets into the weeds, and I hope everybody can kind of follow this. So when you have a health center that is contracted with a QHP, the Medicaid PPS is not guaranteed. Oh, I'm sorry again. My screen keeps timing out. So let me get back to it. Bear with me. Sorry about that. As I said, if you are contracted with a QHP, you could potentially get PPS, but there's no guarantee to it. So obviously, the health plans, generally speaking, are not offering PPS. Only a couple of states are actually doing that. So as a result, if you want to get a contract with a qualified health plan in the future, it really is incumbent upon the health center to look at what they're doing right now. These health plans all have information on health centers, and quite frankly, they already have a disposition towards the quality of care that they think we provide. Some may be true, some may not be true. But the bottom line is that they are definitely not going to offer contracts to all the community health centers moving forward. Now, this is where it gets really weedy. If an enrollee of a qualified health plan shows up at a community health center that does not have a contract with a QHP, you are still guaranteed PPS. However, the problem with this is that there could be, it says could be, there's definitely going to be a cost-sharing issue on the beneficiary side. So if your typical PPS rate is $125 or somewhere in that neighborhood, it's very possible that the enrollee that walks in your door could be liable for up to half of that. So you would be requesting $60 from someone who, as everybody knows, you're never going to get $60 from this particular patient population. And then, of course, you're going to have to bill the rest of it to the QHP, and certainly they're going to deny the claim first off. So it could take you a long time to get that money if you ever do. So a lot of people, I've heard a lot of community health centers say that we'll just not contract with QHPs and we'll get the PPS. Not a good idea. I think that is a recipe for disaster. You will be taking in patients that you will get less money on than your uninsured patients for a sliding, from your sliding fee discount. Any questions on that? Pay for service. Okay. So To give you a little bit of idea of where the plans are coming from, we did a survey about 2 months ago now. 41 states responded, and it's actually been incredibly helpful for us to try to understand where they're coming from. First of all, most importantly, most dangerous thing we found out is, frankly, 39% of the PCAs. We didn't do a CHC thing. This was strictly from the PCAs, and we tried to be conservative on this number. 40% basically have reported little or no interaction with qualified health plans in their state. 60% were not able to negotiate new terms in proposed contracts when they were contacted by the QHPs. Basically, what they were given a contract to sign in sort of a take it or leave it approach. 80% have not been offered PPS, or that should say something similar to PPS. I apologize for that. And most importantly, and this is probably something that Maryland and Delaware do need to be aware of, all products clauses, as well as all payers clauses, they are critically important for all insurance products in the health delivery market, and something that everybody needs to be paying attention to. In a nutshell, all products clauses are basically embedded into existing contracts you might have with a commercial carrier, and what they will essentially say is that if we offer a new product to the market, this existing contract will dictate your current terms. And so if I can kind of play out what happens in these scenarios, you know, most average community health centers might have 10% of their existing population might be on a commercial plan. And of course, of that 10%, you're going to have one contract that might dictate only 1% of that 10%. So you might have a very, very small number of patients being under a contract. And as you know, probably a lot of you would recognize, you know, when you're talking about only a couple hundred patients, you're probably not going to scrutinize that contract as well as you possibly should. Well, imagine if that particular contract, also that contract you have, we'll just use United as an example. If United has a very, very small contract with you, but they go into the become a QHP in your market, they may end up having 10% of all of your patients under the exchange. And if you didn't recognize that all products clause, that reimbursement rate and the other terms of that contract could very well dictate up to 10% of your patient population, and that's where these all products clauses can get really, really bad for us if we're not paying attention to them.
Hello? Shawn? Hi, is everyone else on the call still?
Yeah.
I think he got disconnected.
Hello?
I think he got disconnected. Just give him a few minutes to get back on the call. But if anyone has any questions, you can ask. I know everyone's just getting inundated with all this information right now, but if you do have any questions, Shawn is really great. He'll be more than happy to answer your questions. And if you feel comfortable asking right now, you can also email them to me, and I'll be sure to ask Shawn to respond back to the questions. Hi, Shawn. Are you back?
Hi. No, I'm here. Thought my presentation was so bad you just cut it off. So,
it wasn't.
Was there any questions up until that point that I can answer? Okay.
Any questions? Okay.
Was there a question, Anika?
No, there weren't any questions, and I did tell them that if they have any questions that they can't think of right now, they can email them to me, and I'll email them to you in case they haven't thought of it during the webinar. Okay?
Go to the next slide, please.
Okay.
Okay. So what we've really found out more than anything else, and this is critically important, most of your health centers, almost every single health center in the country, is used to working with the Medicaid side of health insurance plans. There are two sides, though, to the average health insurance provider. One is the Medicaid side, if they have a Medicaid product, and the other side is the traditional commercial plan. Well, almost all of the health insurance plans that are interested in the Affordable Care Act are looking at the product that they're going to be putting out on the market from a commercial perspective. 9 times out of 10, the commercial side of an insurance plan and the Medicaid side of an insurance plan have no idea what the other side is doing. They don't know each other. They don't talk to each other. And we have had many conversations with health insurance plans who will readily admit this. It's not anything that's that's not a secret at all. And so what that means is that it's critically important that you reach out to the qualified health plans and talk with them so they know exactly who you are and what you do, and obviously the amount of patients that you're taking care of. That is the one thing that we have recognized early on that is a critical thing that all community health centers need to be paying attention to. I would also tell you that most insurance companies really look at 2014 as sort of a dress rehearsal. There are certainly lots of health there are lots of health insurance plans out there that are staying out of the game until 2015 when the markets begin to stabilize. Obviously, 2014 is going to be a great year for a lot of people who have historically not had access to care, specifically chronically ill people who will now have access to a health insurance product that they've needed desperately for a long, long time. So you're going to see a lot of transition in the markets, I think, in almost every single state over the next probably 3 to 4 years. And as a result of that, I think it's important that we recognize that while we have a lot of shortcomings on the community health center perspective from a managed care contracting perspective, we have some time to deal with those issues. But the most important thing, though, is that while we thought we were going to get certain protections in the Affordable Care Act, that's not necessarily the case. So as a result, we really need to focus on our internal operations, making sure that we obviously are focused on increasing quality and providing the best care we can at the lowest possible rate. Go to the next slide, Anika. I think that this is actually something that's probably not terribly relevant to this particular audience. I know that State of Maryland actually already had sort of I guess we'll call it a QHP mixer or something like that that the state put together, which was fantastic. But really, what it's come down to is we have come to a point where the vast majority of the patients, once the ACA is fully implemented, the vast majority of our patients that we're going to be seeing are going to be under some sort of an insurance product. As a result of that, obviously, we have the patients that they want, but we need to learn what they think, the way that they operate in terms of the business perspectives that they come from. They don't call them patients; they call them enrollees. Quality and cost of care is really what they talk about, and they're willing to do business with community health centers in terms of cost savings, in terms of ACOs, things like that, but they're only going to do it if it makes financial sense for them. These are mostly publicly held companies, and they have to answer to stockholders, which is a very different issue for us. And as a result of all of these patients, by 2017, 18, easily some health centers could have 75 to 85% of their patients under some sort of a managed care arrangement, maybe having only 10 to 30% uninsured in some cases. And as a result of that, coding is going to be critically important for us. I've been in the PCA world since about the early 90s, and coding issues was a problem back then, although it was less acute. Now it's becoming much more acute, and if we do not understand coding, why coding is so important, we're only going to get worse. I can tell you when I said earlier that almost every single health plan knows something about a community health center, it's because the data that they have on the existing on their existing patients that you might be serving. And it all comes down to coding. Are you coding correctly? Because I can tell you I've seen study after study that says from an insurance perspective that while we claim that we see very, very sick patients, that's not what the data says from the insurance plans. Many of them will say, well, yeah, you do see sick patients, but they're not any sicker than the private side is seeing in terms of the Medicaid population. And that's something we need to recognize. If we are actually claiming that we're seeing sicker patients, the data doesn't back us up at this point. If you do good coding, generally speaking, that is not the case. It will indicate that we do have sicker patients, but on a whole, and you know, I've probably seen data from 5 or 6 Medicaid plans. On the whole, we do not see sicker patients than the average private provider in the Medicaid market. So moving forward, you know, this is really kind of what I hope is the maybe what you're looking for most in this conversation is, you know, what are the Maryland and Delaware health centers going to be doing moving forward? Hopefully, you're going to get contracts. Everybody's going to be involved with the expanded Medicaid and the exchanges in those 2 states. But regardless of that, you're going to have to take probably going to have to take more risk moving forward. Now, risk can be defined various ways. Certainly, improving your contracts with your managed care plans is going to be critical moving forward. Understanding that you know, how your rates are set by them and what they are looking for in terms of increase in quality, which could have you know, a revenue increase on your end. But I would say moving forward that we really do need to be thinking about that medium risk category in terms of independent practice associations and accountable care organizations. Those, from what I've seen across the country, and I've worked with a lot of states on this issue, those are really sort of the sweet spot where I think that community health centers, PCAs, and the health center controlled networks can actually work together and build something that has a tremendous value for all of the health centers if they're willing to get involved. Independent practice associations in particular have really taken off just over the last, I would say, 6 months. I was sort of pushing IPAs now for probably the last couple of years, and I think a lot of people are kind of taking a wait-and-see approach in terms of what the Affordable Care Act is actually going to look like. But independent practice associations, very, very prevalent over on the West Coast, less so on the East Coast. But currently there are 3 PCAs that have developed IPAs, and some have taken their entire membership. Some have taken portions of their membership to build one. The critical thing about independent practice associations is that it's definitely not a all for one and one for all model. Quality is the critical indicator, and if quality is not provided by all of the health centers at a particular level, you really need to think who you want to represent it in an IPA. Obviously, accountable care organizations are kind of all over the place right now. There are so many different variables out there. I would highly encourage you, if you're getting contacted by hospitals or other community health centers or the state to develop an ACO, give us a call. We're happy to take a look at the contract. We do have a person here on staff. Her name is Monica Palgerald, who has done significant work reviewing contracts. Actually, she's been in the managed care world her entire life, and contracting was basically her specialty. We're happy to take a look at those things and see if it actually makes good sense to move forward, or if language needs to be adjusted. The bottom line, though, is that everything that we're doing moving forward requires us to control our quality and control our data. And you're actually very lucky that at least in Maryland, there's a strong HCCN there that can actually help you develop, that can actually drive your increase in quality and actually make a difference. And as I said, managed care contracting must improve. Anika? And I have typically never done this in the past, but I am going to promote a particular product that's out there that NAC created was created in 2012 and was redone in 2013, only because, in my opinion, traveling the country, talking to community health centers, our number one problem right now is we historically have not paid attention to the managed care contracts that we have signed in the past, as well as the ones that are being presented in front of us right now. So as a result, NAC developed a managed care handbook. Essentially, it is a very thorough document on how to go about looking at a managed care contract. There is all kinds of sample language in it. At the end of every single chapter is a checklist that you can go through and compare it next to the contract that you're looking at. Also, on this page, you see that there is that there is actually a webinar series that's attached to this. The first one is going to start, and I apologize, the first one actually is going to start September 25th, and it goes for 5 weeks. It's on every Wednesday. I think the webinars are an hour and a half, I believe. They go from 2 to 3:30, if I recall. Highly, highly recommend that you do this, and as you can see there, if you're a NAC member, this is as good a deal as you're ever going to get. $549 gets you the entire webinar series and the handbook. If you're a non-NAC member, it's $749. Like I said, I apologize for kind of promoting this, but it is critically important. This is the #1 thing that we're facing moving forward. If we get our managed care contracting skills up to a particular level, the Affordable Care Act is not going to be a problem for us, because we are going to get reimbursed at a level that is appropriate to the care that we're providing. Anika, next slide. So this is just sort of what I kind of envision what's going to happen kind of moving forward. If you have a qualified health plan contract, you are going to be in good shape. You're going to get so much business moving forward, especially if you have managed care expansion. And obviously Maryland is definitely in a perfect position for this. But if you do not have a qualified health plan contract, you are going to get overwhelmed with uninsured patients coming through your door, and it's going to be a problem. If you have financial problems now, it's critically important that you deal with the issues now. Make sure that that you increase your quality, get your staffing levels correctly. For those, and we're going to be looking at a situation where health centers may potentially go under as a result of this. If the managed care plans are not willing to do business with you, you're going to have to take a hard look and see what your business, what is wrong with your business and how it needs to change, and whether it's a situation where you may not be able to survive, or you're going to need to potentially merge with another health center. All of those things are really going to be on the table over the next couple of years. Next slide, Anika. And so finally, I think we're in a, and I don't want to present this as being a negative presentation, because I actually think this is everything that we've asked for. This is an exciting time to me. I hope everybody on the phone looks at it that way too. This is everything that we have been working for almost 50 years now, especially in states where they are expanding Medicaid. It should be the golden age of community health centers if everything moves forward as we expect in those states especially. But still, 2014 is a dress rehearsal. Lots of things still need to be fixed in terms of how this implementation will go. So we have a lot of opportunity to make changes. That gives us the opportunity internally. We'll be working externally with CMS and with Congress to make sure that some of the issues that we have already recognized as being a problem are addressed. But you still have time internally at your health centers to work on these issues as well. Regardless, the mission doesn't change, and I would tell you that we had a conversation at the CHI last, I guess it was 2 weeks ago, about your board. The boards are critically important moving forward, and we actually had a long-time community health center governance consultant that I've known for probably 25 years. Her #1 thing that she said is that when she travels the country, and she travels extensively, she said, get your board involved, and you've got to lower the age of your average board member. She said there's just too many times where she goes into the health center, into a health center board of directors meeting, and the average age is 50. We need to engage our young people in our communities. We need to get them involved, because they're going to be the critical portion moving forward. We have to get them we have to outreach to them. We have to get them enrolled in products through the Affordable Care Act, whether it's Medicaid expansion, whether it's the exchange. We have to get them involved, and obviously educate them as to why the Affordable Care Act is so important and the way we need to change our business operations. Getting back to outreach and expansion, please remember, and a lot of people seem to be forgetting this, there's a whole lot of conversation about outreach and enrollment, but when it really comes down to it, we're the only ones that are doing enrollment. They're going to be the qualified health plans are going to be doing enrollment, but when we talk about Enroll America, the Young Invincibles, all of these other groups that are very excited about doing outreach, that's all they're doing is outreach. So it's critically important for the health centers to be the tip of the spear when it comes to enrollment, and get out there and in-reach first to your existing health center or to your existing patients, making sure that they know all of their options, and then reach out to the remainder of the communities that you serve. as I said, I'm not going to belabor this point, run high quality, efficient operations. And then, just as a final comment, I had a conversation with a sizable health center in Massachusetts, probably serves about 20,000 patients. And she told me this about 2 weeks ago, and I think it's the most important thing that I can tell you. The Massachusetts, the connector, as they call it, was up and running in 2009. It is 5 years since then, almost 5 years since then, and they are still taking 600 applications a month, either for Medicaid expansion and or the exchange product that they have. So this is definitely, while we're sprinting to get to October 1st and January 1st, after that it becomes a marathon. And that's why I say take your time, let's do it right as opposed to doing it fast. Anika, that's my entire presentation. Are there any questions that I can take?
Thank you so much, Shawn. Does anyone have any questions? I know that was a lot of information for all of you, but if you have any questions at the moment, please feel free to ask Shawn. He's obviously great and knows all his information. Anyone? No questions at all? Hello? Is anyone else on the line?
Yes.
I hear people on the line, so I know you guys are out there. So if you have any questions now, please feel free to ask Shawn right now. And if you feel more comfortable and can think of other questions later on, please feel free to email them to me, and I'll make sure that Shawn gets them.
And, Anika, my email, actually, I think it was on the first or second slide, too. They can email me directly if they have questions.
Perfect. That works even better. So
I'm sorry.
I think I hear a question.
Could you ask the gentleman, I'm sorry if his name escapes me that fast, but what were some of the best learned practices or outreach tactics that Massachusetts did to have the successful connector program for the last 5 years?
Well, and this is the interesting thing. I would tell I am actually I can get that information for you. The one thing about Massachusetts that everybody needs to be aware of, everybody sort of goes to Massachusetts and say, okay, we need to look to see what they did. Be very, very careful about that. Massachusetts is a very unique market. First of all, there's more doctors in Massachusetts than any other state in the country per capita. Secondly, the Affordable Care Act their connector was created with everybody on board and everybody very, very positive about what they're trying to accomplish. So, and also don't forget that the Community Health Center program in Massachusetts is extraordinarily strong, probably stronger than any state in the country. The Community Health Centers in Massachusetts own part of a plan. They are well connected to all of the hospitals in the area as well. So, but I can tell you what they did more than anything else. And another thing that's very important, they control so much of the market in Massachusetts. Generally speaking, their numbers were up anywhere from 25 to 50% when the connector went live in 2009. And so as a result, they were focused on the people that were coming in the doors than anything else. There was not a lot of specific best practices they had to worry about because it was a total team effort from the state's perspective. Everybody was talking about the connector. Now, in that regard, you should be in good shape in Maryland because you have a very, very strong state-based exchange that is doing the same thing. But I can actually, I need to go back and kind of look at my notes from Massachusetts to see if there's anything specific related to best practices that I can send out, and I will be happy to get that to Anika and send it to them. I would just caution everybody to be very, very careful about comparing Massachusetts to anybody else because very, very different environment up there.
Okay, thank you.
Thank you so much for your question, Anita, I think, right?
Yes.
Just to let you all know that these slides will be available and will also be up on group sites, and I will also email them to you if you can't get access to group sites. Since I have all of your attention, this is, I think, a good time for me to ask you to forward contact information for your designated staff member you have on your team who is spearheading the outreach and enrollment for your center. I hope to be corresponding with them frequently with any upcoming events, resources, or any O&E-related work in the coming weeks. So please have them reach out to me as soon as possible. Thank you so much for your attention. Does anyone else have any last questions for Shawn?
Is there any chance you could go back over the contracting slides and about the all payers clause and that kind of thing? I had to step out of the room for a minute.
Do you just want me to briefly go over that again?
Yeah, if you don't mind.
Sure, I can do that. It's not a problem. And I actually am happy to, because this is the thing that I spend a lot of my time talking about right now. It's pretty simple. And for anybody, and the one thing I didn't say is that the number one thing that every single health center needs to be doing right now is get out every single managed care contract that they have signed that is still in effect and read it. The two things you really need to be looking for, all payer, and by the way, all payers is sort of just another version of an all products clause, and I'll explain that in just a second. But the two things you need to be looking for is, number one, what are the ways that you can cancel your contract? Is the contract an evergreen contract where it simply renews every year? If so, when was this contract actually signed off on? When it was, what year was that? If it's been 5 years, you've got to exercise an out clause and get some new contractual rates. So specifically to your question regarding all products clauses. All products clauses are usually embedded in every single commercial contract out there. There's only 11 states out there that actually prohibit all products clauses. But essentially what they are is it's going to say something along the lines of, and I'll just use United as an example. All of them have it, nothing specific to United on this. United sends you a contract and it says, if we, United Healthcare, decide that we want to open up a new market or propose a new or open up a new product in your service area, you are bound by the terms of this agreement that you're currently signed in terms of the rates, in terms of everything else, and we will simply add you to the network. That's essentially what it will say. Now, here's another thing and this gets to the all payers clause, and this is sort of like it's just kind of a spin-off of the all products clause. And this is one that we've noticed is really happening with the co-ops. So you may want to take a look at Evergreen Healthcare to see if they're doing this. I don't know that they are, but I'm giving you something you might want to think about. What the co-ops are often doing is renting networks from other companies. So, and just as a for instance, say Evergreen needed a network to be developed in a portion of Maryland. They would potentially go to United and say, do you have excess capacity in this portion of Maryland? And United might say, yes, we do. Well, that is an all payers clause. And it's the same thing as an all products. They could, the United contract would essentially be a new product for United Healthcare, and they would be using your existing health centers in that regard as well. So a new product could be coming directly for a new product. It could be a United product, or an all payers clause could be the same thing, where they're simply renting out their network, which is you, and using the existing contract rates and all the other terms will apply to this new contract. The only thing that would happen on your end is you'd probably get a letter saying you are now part of United Plus, or you would say that you're now part of this particular co-op network, something like that. And it would just simply be a letter. There would be no renegotiation of the contract if that all payers clause is in there. Does that help you?
Yeah. Now the QHPs, from what I'm being told, we have existing contracts with most of them, and they're just saying for right now we're just letting it ride, and we'll be paid the same way we're getting paid now. Is that what you're seeing?
That's basically an all products clause, because you probably should have gotten a letter saying that whatever the name of the health plan is part of the exchange product or exchanged products that Maryland has approved, and the existing rates will continue on.
Okay.
So that's basically what they have done, is implemented invoked an all products clause.
Okay.
So as I said, two most important things: find out when's the last time you renegotiated the contract, and if you need to opt out of the contract or opt out or renegotiate, that's the most important thing. because you are definitely in a powerful position right now because of the number of uninsured patients that you are going to, that will be flipped over into paying patients, and they need them.
Thank you so much, Shawn, for the explanation. Does anyone have any more questions?
Anika, I'm going to go ahead and send to you a document that we sent out probably 3 or 4 months ago. It was actually created by the American Medical Association, but it's specific to the All Products Clause. I'll send it to you, and then you can go ahead and forward it on to the people, either your entire membership or the people on this call, whatever you choose.
Wonderful. Thank you so much, Shawn. That would be really helpful. Also, Shawn, I have a question. Besides the trainings that you just went over, are there other trainings that are going on by NACHC?
Specific to this issue, Anika?
Specific to this issue, yes.
Actually, we are actually just in the process of setting up a new training that we're going to roll out probably first of next year. If anybody was at the CHI in Chicago a couple of weeks ago, we did a learning lab and used it sort of as a beta process where we basically are training health centers to look at managed care contracts from a team perspective, meaning, you know, if anybody's been around for a long time, the way a traditional managed care contract got signed in the past was the CEO read it and the CEO signed it. We do not recommend that process going at all. And moving forward, we really want to see a team approach to looking at all managed care contracts that are presented to a community health center. And when I say team, I mean at a minimum the chief medical officer, the chief financial officer, the chief executive officer, potentially the chief information officer if there's one on staff. What we are going to do moving forward is we are going to develop regional trainings. Regional could be a couple of states if they're small, but it also could be one single state where we come in and we obviously know what's happening in your state in terms of, you know, whether it's a Medicaid expansion state, you know, what the exchanges are doing, and we actually will tailor a a managed care contracting training specifically for the states that we're working with. So, and obviously a team approach again. So if we have it, we definitely want to see at least, you know, 3 people coming from each health center to do that. And so that's going to be coming up in the next, well, we hope to get it rolled out by the first of next year for sure.
Wonderful. That's great. Thank you so much, Shawn.
Sure.
So if anyone else has any questions, please feel free to ask now, or I have Shawn's email address and phone number up, and please note them down and ask him yourself whenever you have time or whenever you can think of any. I would like to thank Shawn for taking his time to explain everything to us, and you did such a great job, and thank you so much for the extra trainings that you just told us about, both that are happening in the coming weeks and the ones that are coming up in the coming months. So thank you so much for that, Shawn. And if anyone else doesn't have any questions, I will be closing this webinar now. Okay, great. Thank you so much for joining, everyone. Thank you, Shawn. Thank you to all the participants. Please forward me the outreach and enrollment staff email addresses and phone numbers so I can be in contact with them. Thank you so much, and have a great day, everyone.
Thank you.
Thank you.